that have been delivered on this platform. That have been delivered on this platform by Dr. Bhaskar Mukherjee in terms of basic sciences, basic phenotypic presentations, how symptoms or how phenotypic presentations evolve over the developmental trajectory. Now the next couple of sessions are going to be on how do we intervene, what do we do, and so on. So I hope all of you get your time's worth, because it's actually middle of the week, and most of us are busy clinics in the evening time, including me and including our chairperson today. I hope he's there. So just give me a minute. I'll message him. So I think by the time he logs on, I think he's reaching his clinic and he'll have to log on in the next few minutes. We have for this session to chair, we have Dr. Karthik Rao. And I know a lot about Dr. Karthik Rao because he is my friend, and we have done psychiatry together. He's a couple of years junior to me. Yeah, Dr. Bhaskar is on. Welcome, Dr. Bhaskar. We have just started. I'll introduce the chairperson and then I'll hand over the proceedings to him. So we have Dr. Karthik Rao. He's done his MD psychiatry from TN Medical College and BYL Nair Charitable Hospital, Mumbai. He's a consultant psychiatrist. He runs his Omkar Mind Care Clinic in Mumbai, and is associated with the BACS MG Hospital, Andheri, and Holy Family Hospital and Research Center, Bandra in Mumbai. He has, to his credit, he has managed a inpatient nursing home and de-addiction center for 10 years. His forte is actually management of addictions, and he's very keen. His clinical observations are quite astute in that field. He's done very well in the field of addiction and has appeared in many talk shows on TV, conducted many mental health workshops for schools, colleges, and corporate organizations. With this, I hand over the proceedings to Dr. Karthik Rao. And just a few points, few reminders before we begin. Please, everybody be on mute except the speakers. Whatever questions we have, please put them in the chat box so that we can pick them up one by one. Please make the questions brief and precise. Try and avoid personal anecdotes and experiences. Once the talk is over, Dr. Rao will take up the questions. And before I forget, we have all the talks on our YouTube channel. So please subscribe so that all the episodes are available in consecutive manner, so we do not miss on any. Over to you, Dr. Karthik.
Thanks, Dr. Malay. Malay is my senior, and we are like good friends in so many years, last almost 20 years. And it's a great pleasure to invite Dr. Bhaskar Mukherjee, and we are always inclined to listen to his informative talks. And today's talk also is going to be very interesting and is going to be very helpful in our clinical practice, because he's going to enlighten us on psychopharmacology of anxiety and depression. And there he's going to highlight selection, duration, and augmentation of what all our armamentarium we have. So over to Dr. Bhaskar. I'm sure this lecture will be very enjoyable and informative.
Thank you. The thing is, this is going to be the last basic science series in Brain on Wednesday. Once this series in 2 more lectures, we are going to directly proceed to every clinical topic. With this introduction, I am going to go towards today's presentation where I will talk about the what we have learned till now in this series and what we are going to talk today. That is the psychopharmacology of neurotics, focusing only on depression and anxiety. But I have kept one day reserved for OCD and things like that, and along with one day for somatic syndrome. With this, I am starting my presentation. This is a very bland presentation because today I want to just focus on the information. So, when we start our clinical practice or in fact,
Bhaskar, just one
yes,
sec. I think there is some disturbance and echoing from your side. So just see if you can do something
let
so that
me
the
just
audio quality is better. Otherwise, presentation is fine. You are also visible.
so something is just a minute. Now, now I hope the sound is better.
Yeah, better. So let's proceed. We'll see.
Okay. So, whenever we enter the psychiatry residency, the first type of patients we see is patients who complain about their problems and things like that. And that used to be the basis of the old name neuroticism, where patients come to us and complain to us, in contrast to psychoticism, where society used to bring the patient to us. Unfortunately, even this 200-year old, 200-year plus old name is better in terms of taxonomy than what we did. Anyway, so in this session, started exploring what is behind this set of symptoms. And we started with sickness or illness behavior. We knew that the all neurotic spectrum symptoms are just different type of manifestation of sickness behavior, which is ubiquitously present across all species. It is a neuroimmunoendocrinological condition that gets triggered whenever any animal brain faces functional demand that is far greater than its ability to function. That functional demand might come from inside the body, just as some infection or some organ disease, and come outside of the body from external environment like some social change and other. And all the genetic and pathophysiological underpinning of sickness behavior is the cause of neurotic spectrum symptoms in us humans. And it extends beyond human. If you look around the other animal species, you would find the same thing. Excessive grooming in cat and other mammals, self-biting in cat and other mammals. Then there is ritualistic self-destruction in eagles. Then there is also various other behavior in animal kingdom that can actually explode the sickness behavior. Then we learn that our body doesn't have a single brain. There is a central CNS brain, and then there is a brain in every organ of our body. They are called intrinsic autonomic nervous system of specific organ, and they control everything in a particular organ, be it liver, be it heart, be it kidney, be it gastrointestinal tract, be it urogenital tract. Each and every organ of our body has one of these. And so this gut is second brain is very, very, very odd and misinformation. And these brains are connected to central brain with bidirectional neuronal, hormonal, and immune system connection. Whatever happens in central brain is reflected in peripheral brain, and whatever happens in peripheral brain ultimately gets reflected in central nervous system brain. And that is how brain controls every single aspect of body function. And ultimately, that leads to exaggerated or aberrant sickness behavior in every animal species. Then, brain has thousands of pacemaker neurons that control bioelectrical grid of brain. These pacemaker neurons are the cause of all functional neural networks in brain, and they maintain the brain working and functioning of the whole body and brain. And a lot of symptoms of sickness behavior are controlled by these neurons. And ultimately, various aspects of sickness behavior. In some specific animal, sickness behavior is more of withdrawal behavior. In some animal, it is more of a aggression and resistance behavior. These are controlled by this pacemaker. So with that, now we are going to come to treatment properly. First, what we learned so far, and now what we are going to deal today. If we further analyze the sickness behavior, we would come up with a mixture of so-called approach trait and avoidance trait, or if we give it our known name, then obsessive compulsive personality trait and attention deficit personality trait. These traits in various combinations present in the people who show exaggerated sickness behavior. Then for the ease of description and for the ease of management, we can roughly divide these people into two groups. The attention deficit trait prominent obsessive compulsive personality trait, or attention deficit trait non-prominent obsessive compulsive trait. These are the two varieties of people who come with neurotic behavior. Some would show excessive obsessive compulsive behavior, some would not show that much and would rather show superficial attention deficit behavior. Now, in secondary attention deficit trait prominent behavior, we would find different other manifestations. Some of them would come with borderline personality-like presentation, and they would be previously tagged by their previous psychiatrist as borderline personality, or if the psychiatry is more critical thinking, then impulsive compulsive spectrum, then there would be some who would be known as dissocial personality if the psychiatrist is more influenced by UK and USA teaching. So the name would be same, but the name would be different, but the presentation would be same. The person would be having strong obsessive trait along with attention deficit trait, and so both of them either together or alternately. Then comes body focus repetitive behavior. We are going to deal it in a separate full episode because it comes in a variety of form, and it ultimately gets divided into somatic symptom delusion, somatic symptom obsession, and things, the various names like that, and also hypochondriasis and various other things. So that makes a separate episode. Then impulsive compulsive traits like addiction to substance or behavior, they would also actually have prominent attention deficit traits along with also prominent obsessive traits. The more obsessive, the more tendency of using opioid, cannabinoid, and alcohol along with benzodiazepines. The less obsessive, they more into various form of stimulant addiction. Then there would be recurring low mood and overthinking associated with periodic hyperactivity, and they would get termed as bipolar 2. This group is the most unfortunate one because this group would get tagged as bipolar 2. This group would never get the adequate dose of antidepressant they require. This group would always complain, I am not well, but psychiatrists habitually treat them low because the traditional teaching of psychiatry is you should never make the patient fully functional in bipolar tag. We forget that these patients need their hyperactivity. We might term that hyperthymia, we might term that hypomania, we might term it whatever we like. But that is the normal state of this people. If we reduce that and if we make the person perpetually this time, we are not doing any service to the person. We might be more thinking about what if the person goes really high, but that seldom happens because these people are by nature hyperthymic and they would stay like that. But anyway, that is one of the biases of psychiatry that we should be aware. Then there would be obsessive compulsive personality with high attention deficit and dominance, and they would get narcissistic tag. This would be the presentation where the person has secondary attention deficit trait prominent. How we can understand that if the person has secondary attention deficit prominent, whenever we use that term, we have to understand that we have to define the patients. Now, most of the time, unfortunately, we have to rely on clinical course that is observed by us rather than any specific test because in our country, the longitudinal history is not readily available. If it was readily available, then the childhood history would have shown us that there is underlying attention deficit trait, there is underlying various indications of it as well as obsessive trait. But except in metros, in other parts, only highly educated and highly conscious parents report this. If we are fortunate to have parents accompanying the patient. So it's more of a clinical evolution notice. There would be some other indication, like if you use this execution measure scale, there are some. that might give you some idea that these patients have this executive trait. But again, they are not really reliable because they are more of a subjective measure. They are not objective. However, we defend our scales, however, we swear by our psychometric scale, none of our scales are objective. They are just trying to quantify the subjective feelings. So, any other way we can do? If the patient is elderly, we can do a functional MRI or uh, other functional neuroimaging like PET or SPECT, and we can show hypofrontality. Unfortunately, this hypofrontality demonstration in a single PET or SPECT or functional MRI doesn't say whether it is present since birth or whether it is present very recent. So there are ways, but each of the ways are not satisfactory and not very reliable. So standing there, longitudinal clinical observation is the only way that can give us some idea about what we are seeing. Now, in some patients, this episode, the first episode specifically, sometimes present as first episode mania or first episode psychosis, and since then, they gradually develop the various other symptoms and get termed as deficit symptom predominant schizophrenia, which is actually nothing but a person having recurrent depression and neurodegeneration, along with past one or two episodes of psychosis, or resistant bipolar depression, which is again just recurrent severe depression and possible neurodegeneration, along with unfortunate one or two past episodes of mania. Now, if there is no prominent secondary attention deficit trait, then there would be gradually depending gradual onset sadness with multiple episodes of severe anxiety and panic. There would be again a group of somatic symptoms. There would be gradually worsening obsessive compulsive symptom with very withdrawn behavior, and there would be sudden or gradual suicidality with any of the other three. Again, we would give them different names. This group would go into bipolar 2. This group was going to bipolar 2 and would be treated with unfortunate anti-epileptics and various other things. They should be getting stat diagnosis of primary negative schizophrenia or deficit schizophrenia and would spend their life with antipsychotic. This group, if they are lucky, would get severe depression with anxiety, and if they are not lucky enough, they would go into bipolar 2. So again, this type of diagnosis doesn't help the patient, rather complicate their lives. Now, those who are unfortunate enough would also get gradual onset chronic psychosis with it and would get a stamp of schizophrenia throughout the life. Without understanding, there is no solution. Now, we have to start with our approach to the patients. We have to forget our trauma. That trauma we have been brainwashed with since the first day we entered subject. There is no trauma. Patient would say a lot of things that has affected their emotion. That doesn't mean this has caused any brain symptom. Rather, these are the people whose brain ruminate on negative symptoms, negative events, negative feelings. These are the patients who go on finding negative connotation to everything that is happening to them. And so, in them, if we focus on these negative events, we would just go on running behind red and nothing. So the only important trigger that needs to be taken seriously is in recent infection, other systemic disorders, and major injuries to brain and body, because all these would start the immune cascade that would be amplified by brain, that would be amplified by their endocrine system, and ultimately would cause the severe changes in the brain. We are paid to listen to the soft stories of patients, but we have to understand they are just soft stories and nothing else. These events didn't do anything. Nobody is sure that the 3 year that sexual abuse that patient is destined at their 3 years of age, whether it has happened or not, or whether they are imagining it. Nobody is certain whether the physical punishment given by the parents and teachers are even true or not, or whether they have done anything or not. So we are just listening to the sob stories to create rapport. We are not expected to associate it with sob stories with patient's pathology. There is none. And as I have shown in last 2 episodes, that full life history starting from birth and through 3 generation family history of every non-communicable disease along with psychiatric symptoms is far more important than any early life trauma or any trauma, because trauma doesn't do anything. Trauma gives us nothing, but full life history, 3 generation family history gives us everything that we need. We get to know the genetic trait we are dealing with. We get to know the systemic associations of the genetic trait. We get to know what complications we are expecting in the future in the evolution of disease. And we get to know that our family history of strong family history of diabetes means our drug is not going to cause diabetes in that patient. Diabetes is going to develop DNA, and it is true for all other non-communicable diseases. Then, how to approach would be we should note the full body features of patient and be conversant with world of scale, May scale of minor clinical element. The interesting thing is there is another way to look at it, but again, I am saying this knowing fully well that they are just historical facts what mentioning, but not really relevant to today's world. If anyone goes into history of medical science, be it Chinese traditional medicine, be it Indian traditional medicine or Ayurveda and Siddha, be it Islamic what traditional medicine or the medicine that developed during early Islamic period, which is known as Union medicine today, or be it Egyptian traditional medicine, we would find that they have tried to classify human temperament by various external observable features. In Ayurveda, they used to think by Vata, Pitta, and Kapha. In Unani, they have added another element. In Chinese traditional medicine, they also added similar things. And all these, unfortunately, were that time's idea of classifying human beings based on their external observable phenotype. Unfortunately, we never did that. If we had done it, if we had followed that with Mehes scale, Waldorf scale, and various other minor physical anomaly scale, since we have access to them, we would have come up with far better phenotypical classification of patients with various psychiatric vulnerabilities. So I am not saying to follow Ayurvedic classification or even classification. I am saying let us recreate their crude attempts with our finer technology. And if every psychiatrist start measuring minor physical anomalies in their patients and start characterizing them, then by end of 2 decades from now on, we would get a prominent psychiatric dyspathology. And as you slowly try to apply this scale with confidence, you would start noticing more and more expanded minor physical anomalies that are not there in Mehes scale or Waldorf scale or neural modification. But you would find that they are worth mentioning, they are worth listing, and ultimately you would come up with a checklist of around 150 to 200 minor anomalies which are associated with various psychiatric symptoms. And with that, ultimately, we would develop a clinical genetic dysmorphology of psychiatry. Someday, we would be able to do it, but that can only be possible if everyone starts trying this and starts listing their findings. Then comes the pharmacological intelligence. Basic understanding of psychopharmacology. Since these things are brain-wide phenomena and many a time brain and body-wide phenomena, there is not a single neurotransmitter responsible for this. Rather, these are brain and body-wide network, pathophysiological network that is doing that, and the network involves various genes, various omics pathways, various brain pathways, various brain and body pathways, and brain and body pathways would involve neural circuits, immune circuits, and neuroendocrine hormone circuit. It is impossible for the five sacred neurotransmitter of psychiatry to do these things. So serotonin, dopamine, noradrenaline, glutamate, and GABA is not doing it. So the drugs which are going to treat, which are treating them well since last 70 years, are not working via these pathways. So we should stop thinking in these terms. Brain has literally thousands of neurotransmitters, and hundreds are being discovered in every 5 to 7 years. Joanna Moncrief would be a black name in psychiatry, but she has actually showed that serotonin is not involved in possession of any symptom. That is a good thing. Although her intentions were very, very bad, and her intention would always be bad. Low mood is never the priority. Low mood is the descriptive name which comes in a form of depression. If anyone has read the history of psychiatry in 1970s, 1930s, 1940s, they would know that all these names that we now use to describe the neurotic spectrum comes from few people discussing in cold restaurants of America with cold beer in hand and voting on giving some daily use names, some medical names. Depression, anxiety, dysphoria, anhedonia, they were never medical names. They never had any medical meaning. They don't have any intrinsic medical meaning. All these were given by people who actually created DSM-3 along with the misgotten biopsychosocial theory and along with various other things. And so something which has no biomedical meaning, something which has no scientific meaning, should not be used to tag a spectrum of syndrome complexes. So depression doesn't mean low mood. Low mood is even redundant with cross pathophysiological understanding of this symptom, and so the decision to start treatment should not even dependent on low mood. And that antidepressants, unfortunately, India, which their name is maligning them all because they don't elevate mood. They don't have any power to elevate mood. Someone is feeling low and they take a Prozac, they take a venlafaxine or Effexor, they would not feel better. That is cannabis we are describing. That is alcohol we are describing. That is ecstasy we are describing. That is cocaine we are describing. But that is not definitely antidepressant we are describing. If we pop something and it makes us instantly better, then that is euphoria. Euphorians are not antidepressants. So the name antidepressant has no meaning. These drugs work completely different. They increase various areas of it. This is some of the ways, but this is not a exhaustive list. I have no freedom at this moment to talk about all the pathways. So, because that would take us more than few days. So, I have just given the main pathways. They manage and modulate cellular matrix formation and destruction. They manage and modulate cellular proteostasis, and they manage and modulate the pathway that deals with intrinsically destabilized protein splitter. They also cause epigenetic modification of DNA and RNA. They also cause modulation of stress sensing and yes stress sensing pathway. They cause increased neurogenesis and gangliogenesis. They cause increasing and correcting of neuronal migration. They modulate neurovascular tones and neurovascular unit function. They cause remodeling of neural and glial microtubules. They cause enhancing synaptogenesis and synaptic remodeling. They modulate and balance cell division, cell growth, apoptosis, and autophagy in brain and all over the body. They modulate adaptive immunity and crosstalk between immune system and neural circuit. They modulate innate immune signaling and DMP, that is damage associated molecular pattern, and PMP, that is pathogen associated molecular pattern pathways. So these are the major subgroups on which they work. Each of these, let's say this has thousands of subgroups, each two. All of these has thousands of subgroup, and ultimately, if we are going to discuss how this drug work, that would take a few days long series. But none of them work by serotonin, dopamine, glutamine, noradrenaline, and GABA. That is just our faulty understanding, and which has been promoted and magnified by pharmacology, because saying this drug works via serotonin doesn't take any RNA. When we start treating these people, there has to be a layered pharmacological approach. Monotherapy is not the way to go. If we are giving a patient monotherapy from the first day and the patient is doing well, we should seriously ask ourselves, does the patient even need treatment, or some cheering, some human connection, and some hope induction via psychotherapy is enough? Since we are not dealing with a single disease or even a spectrum of disease, rather we are dealing with 20,000 plus genes containing a network, and God only knows how many zillions of epigenetic chains. It is only natural that we start with thinking in the form of rational psychopharmacology. Antidepressants are cornerstone, but they are going to work after a lag period of 4 to 6 weeks. If we start a patient on drug and the patient comes in 7 days, then definitely our medicine is not working. That is our placebo effect, the treatment environment placebo effect, and the patient's belief in these two, that is causing the change. And we should be truthful enough to say that to the patient. Otherwise, when the patient would see the real drug working after 4 to 6 weeks, they would be underwhelmed. There is a huge chance that first few days good mood would later disappear, and patient would say drug is not working. Along with that, patient would also start complaining that they are getting various side effects, Unfortunately, when there is also effect and side effect typical to the drug, that is going to appear after 4 to 6 weeks. So it is up to us whether we are calling the patient after 7 days or 10 days or 2 weeks. But we should start explaining to them that this visit is not due to see any significant changes. And if we see any changes that is beneficial, we should directly talk that these are placebo. Now, when choosing antidepressant, we have to understand that there is no favorite antidepressant for any patient. There is no antidepressant that fits everyone. I give escitalopram because I like the smell and look of it. Doesn't work. If I am giving escitalopram in every patient, then I can be pretty sure that my patients are getting better roughly 50% due to escitalopram, roughly 50% due to other things. Similarly, I find paroxetine good. I find diselafexin good. I find X drug good. No. If I am finding any drug better than other, then I am actually showing my cognitive bias, because no drug are better than other. In a particular patient, some drug would work better than other. That is true, based on their genetics. But not every patient would respond favorably to a single drug. So there is some issues in our patient group who present with neurotic symptoms, some escitalopram sensitive group, some diselafexin sensitive group, some paroxetine sensitive group, some fluvoxamine sensitive group, some fluvoxamine and sertraline sensitive group, some sertraline sensitive group, some vilazodone sensitive group, some vortioxetine sensitive group, and some people who are not so severely genetically biased, and they can do percentage well to all drugs. That is actually a more apt description of our patients. So standing there, neither drug should be favored or shunned. No drug is there which is bad for all, or no drug is there which is good for all. So if we are talking about personalized prescription of medication, then first thing would come whether the personalized use can be guided by you. Unfortunately, what we have is very, very gross. No shortcut. And the gross idea is more anxiety symptoms call for antidepressants that have more sedative properties. But again, a note of caution. Depending on personal genetics, sedative properties can change into activating properties for some people. And similarly, activating properties can change into sedative properties for some people. So, for most patients, escitalopram might be a sedating drug, but we would get plenty of patients who cannot sleep with escitalopram. For most patients, fluoxetine is an activating drug, but we would find plenty of patients who sleep well with fluoxetine and who doesn't like to take fluoxetine in the morning. So exception is not proof of rule here. Rather, there are always rule of majority, rule of minority. And in every drug, when we say it is activating, we are saying the rule of majority. That also says that rule of minority exists. For a and for a Hello. I hope I have not been disconnected.
No, you are visible, but I mean your
Slide has gone
present. Yeah, you are audible.
because the
No.
thing is, emergency call came.
Yeah. Okay.
So the first idea is to start monitoring heart. We are fortunate to have smartwatch and smartwatches. A cheap 1,000 rupees or 1.5 thousand rupees smartwatch with smartphone integration is good for all our patients. And we should start telling patients to wear a smartwatch, which would say activation, rising resting heart rate, rising resting body temperature, more movement trails indicated by watch, and more REM associated awakening and more fall in saturation during sleep. All these parameters are easily measured by any smart ring or any smartwatch. We don't need Apple Watch. We don't need Galaxy Watch. We don't need Garmin Watch. Just a plain Firebolt, just a plain port, just a plain 1,000 to 1,500 rupees smartwatch is enough to do all this. And we don't need to make it medical grade measurement. Just our assumption is enough. Now, when we have the basic rule of how to select antidepressant very, very smoothly, we should also understand that first antidepressant should be supplemented with a suitable autonomic nervous system dampening agent, depending on the resting heart rate. If the resting heart rate is below or around 60, prazosin or ondansetron helps in some if you want to avoid propranolol at all costs, but none of them are superior to propranolol in 90% or more than of our patients. And propranolol is a very good drug. Psychiatry unnecessarily blamed propranolol without understanding that all the characterization and various other things that were done to beta blocker were done by medical marketing to promote next generation of molecules. So neither propranolol nor any beta blockers are associated with all the serious side effects that we have been told. Since 2010 to 2015, the data is getting reversed and more papers are coming on which says beta blockers are almost essential in all non-communicable diseases to reduce the morbidity and for sedation, melatonin, benzodiazepine, Z drug, or DORAs all can be given. If patient has problem in initiation, maintenance, as well as early morning awakening, melatonin would not be a single good agent. We need to supplement with benzodiazepine or Z drug. Depending on whether Z drug is good or benzodiazepine is good, I would say both are addictive. It all boils down to on which patient's response better, rather than avoiding benzodiazepine thinking they are addicting and promoting Z drug thinking they are not addicting. Z drugs are almost as addicting and as dependence producing as traditional benzodiazepines. And benzodiazepines reduces autonomic activation better than Z drugs, being a good anti-epileptic density. Now, again, I am going to stress on placebo. because in our clinical treatment, placebo play a massive role and we seldom think about placebo. So total effectiveness of any medication or any surgical procedure is the perceived effectiveness of the procedure by patient plus minus confidence of treating physician in that medication or procedure. Less confidence is more cognitive bias for patient and less placebo and more nocebo response for the patient. Plus real effectiveness of the medication and procedure. And trust me, these two are more important. Your confidence and patient's confidence would determine more treatment effect during initial period rather than the drug's efficacy. Nowadays, lumefantrine is being promoted by Shan, and many of us are going to use that. Please remember, we are not going to see the real effectiveness at first. So do not get excited or do not get seriously negative about lumefantrine just based on what you see in initial days. Antidepressants start working after 4 to 6 weeks and take up 2 to 6 months to fully work and reverse the treatment possible pathophysiological changes. So it is always the highest tolerable dose that works fast. Means, let's say we start with escitalopram. We first start at 5 mg or 10 mg or 15 mg if you are brave enough. Standard is 10 mg, but then gradually increase the dose for initial 4 to 6 weeks and go to a respectable 20 or 30 mg and then wait. If the patient is getting better by the end of 2 months, then wait some more. If by 6 months the patient is all right, then start reducing the dose. Rather than starting with 5 mg, waiting there for 2 months, then increasing it. The second one is more guaranteed to cause more treatment problem. Initially, go to the full therapeutic dose that is tolerable by patient and wait there. Rather than starting at 5 mg, going to 10 mg after 1.5 to 2 months, that might initially keep the patient to you, but ultimately that is going to make the patient averse to treatment. That would make you less patient than is possible for you, and definitely that would not make you famous. So now comes the residual effects. After a drug fully or mostly works around 4 months, there will be various residual effects that patients may present with. And unfortunately, each of the residual effects would be blamed on drug. Rather than we understanding and explaining to the patient that these all are residual symptoms of that illness that is being treated by drug. There would be dysphoria and anhedonia. Patient would come and say, my ruminations are low, my restlessness are low, but I am still not happy. I am not feeling good. I am still not finding energy. That is very, very normal. In less than 30% of patients we treat with any drug, they would say, I am completely well. And again, I am saying, if a patient is saying to you that I am completely well with a single antidepressant, with a beta blocker, and with or without melatonin, then start thinking seriously whether this patient needs long-term treatment or not. Because these patients who respond so beautifully, either a super responder or have strong placebo effect, or we are doing something wrong and we are treating someone who doesn't need treatment. So residual symptoms are rule rather than excuse. When dysphoria and anhedonia comes, patients become Google smart and say these are the effect of antidepressant. These are what caused by antidepressants. Antidepressants are making me emotionally blunt and things like that. You have to explain to them that is not the way. Actually, the antidepressant has given the brain some functional ability, but not full. So the brain is still facing difficulty. And brain needs more ammunition in dealing with that. Similarly, there would be attention deficit and forgetfulness. Patient would again blame these are due to drug. We have to make the patient understand it is not the drug effect, rather these are the residual symptoms. Then anger and assertiveness. This is dangerous because there would be trigger happy people among staff who would be dying to stamp the patient bipolar. But this is not bipolar. This is just a patient who had underlying severe obsessive trait, had various attention deficit traits, and they are now actually uncovering those traits, and that needs to be understood by family as well as patient, and more importantly, the doctor themselves. Anxiety and panic residual form, same thing. Lethargy and fatigue, same thing. Persistent obsessive compulsive symptoms, same thing. Persistent suicidal thoughts, same thing. Excessive sedation and persistent pain. All these are just residual symptoms. They have nothing to do with the drug. They are not side effects of the medication. They are definitely not caused by any of our treatment. It is the nature of the beast. Now, if there is residual panic, anxiety, and residual obsessive compulsive symptoms, we need to give second antidepressant that would suit the patient. We need to give low dose antipsychotic because that would reduce the panic, the anxiety, and residual obsessive compulsive symptom by reducing the hypervigilance. We should increase propranolol. We can add clonidine, add memantine, add naltrexone, although naltrexone doesn't work that well here, and add amantadine. We can add therapy of patient choice with other medication. We should not add only therapy and say therapy is the first choice. Therapy is not the first choice. Then all the things, residual dysphoria, residual anhedonia, residual lethargy, residual weakness, residual forgetfulness, anomia, residual attention deficit, they are actually the underlying attention deficit trait uncovering. First treatments would be modafinil and armodafinil. Levomilnacitran is not available, but it would have been a good choice. Bupropion, pramipexole, ropinol, amantadine, atomoxetine, methylphenidate. In excessive sedation, they would also work, but first we have to see whether we are causing the sedation ourselves. This is the only area where we have to think whether the drug is causing it or not. Otherwise, the dysphoria, anhedonia, lethargy, weakness, forgetfulness, anomia, attention deficit, they all are due to residual background untreated attention deficit. And we really need to treat them for the attention deficit. persistent pain. We would talk in details about persistent pain in somatic symptom, but here we can use duloxetine along with the primary antidepressant, levomilnacipran, milnacipran. Unfortunately, they are not available. There's venlafaxine, and atomoxetine. Now, we come the second group, the group where there is strong obsessive compulsive trait along with strong attention deficit trait. The so-called borderline, the so-called bipolar 2, the so-called dissocial personality, the so-called various bipolar illness, and the people whose life we psychiatrists make miserable. If we are to be blamed for disaster of life of a group of our patients, then this is this group. We make them live their worst. So there are two cornerstones of treatment: antidepressant, anti-impulsive medication. The anti-impulsive medication might be naltrexone, works very well, antipsychotic, low dose, anti-epileptic, varenicline, memantine, lithium, autonomic nervous system blocker, indoxafen, or any other protein kinase inhibitor, means Janus kinase inhibitors would also work, means other protein kinase inhibitor would also work. The main problems of these patients are their addiction liabilities and their various behavioral worries problems. After sufficient control of obsessive compulsive trait, most of them needs to be given specific attention enhancing medication for the control of their addiction disease. Some of them would respond well to various traditional attention enhancing medication like armodabilene, modafinil, atomoxetine, bupropion, or methylphenidate. Some of them would be irritable with those medication and need alternative strategies where they need an attention enhancing medication without associated irritability, means milder one. Amantadine is one. Then comes various so-called doping agents like trimetazidine and various nootropics which athletes use as doping agent, but in a proper dose. I am not saying that L-carnosine won't work or L-carnosine won't work, but the dose needs to be proper. Minimum 2.4 gram to 3 gram and ideally up to 4 to 5 gram per day. If we give in that dose, it will work. If we are giving coenzyme Q10 along with the L-carnosine, yes, we can give it, but the dose needs to be 300 to 400 milligram per day. If we want to give nutraceutical, we have to understand they need very high dose. So after a suitable time frame, these group would have a variable dose of antidepressant, anti-impulsive medication, attention enhancing medication, and autonomic nervous system blocker.
Bhaskar, can we wind up in the next 5 minutes or so, because we'll have some questions also.
So these are the things. This is the last slide.
Oh.
So we have to understand that this is just a scratching of surface. The extension would be various endocrine system and their destabilization management, pathophysiological formulation and management of slow progressing psychosocial mania, pathological formation and management of acutely emerging psychosocial mania, which is sure to happen in this group. Adolescent onset, but adult and middle age onset is not discussed here. Metabolic syndrome, I have not talked, and eventual neurodegeneration and various dementia syndromes, I have not linked. Various other things could be there, but due to time restriction, I am ending there. Just remember what you saw today and understood today is foundation for proper management of this group. But this is just a foundation course. This is not all inclusive. With this, I am ending my exhaustive torture to you.
Thank you, Bhaskar. Over to you, Dr. Karthik. Your comments, questions.
I think it's such a nice experience to listen to Dr. Bhaskar and learn his insights, so different way of looking at our daily patients which we see. And I think today's topic is so important for our clinicians because this is like a bread and butter cases which we see every day with anxiety and depression being so common in our clinics. And I think the way which he highlighted is those, so many patients which we see for anxiety, and they may be having underlying layers, as Bhaskar has mentioned, that underlying attention deficit disorders, underlying, patients which may be having even chronic underlying, where patients may develop some kind of neuro degeneration, and then later on may have psychotic symptoms or even bipolar symptoms or bipolar depressive symptoms, which may be long-standing. I think this, as he is highlighted again and again, that we need to take a very detailed history and find out even maybe family history going up to 3 generations for such kind of neuro or psychological problems in the family. So I think this is very enlightening, and that will probably give us more cues at what medications we can give for patients coming to us with anxiety, depression. As he also mentioned, resting heart rate and manipulating the autonomic nervous systems through either beta blockers and benzodiazepines, and choosing the right SSRIs. And as patients, I think which he highlighted also very nicely was, as patients developed improvement in the 3 to 4 months, but the residual symptoms would give us more ideas to add on maybe a second antidepressant or maybe stimulating agents, because underlying as he mentioned, these medicines may improve their underlying attention deficits. So these are things which will probably help patients in the long run. And as he also mentioned, underlying obsessive compulsive traits may be there, or obsessive compulsive symptoms may be there, which may require maybe an additional SSRI or even polypharmacy in case there's underlying pain which is not settling down with it. Maybe we may have to add duloxetine. And also the impulsive patients or the impulsive symptoms which may be remaining, which we may have to add maybe a mood stabilizer, or we may require medications like lithium also to help them. And I'm sure he's also very famous for adding naltrexone and some of these medications which have not routinely used, but I think if we start using and seeing changes in patients, I think a lot of, I'm sure Bhaskar also would have mentioned that there are patients who sometimes develop weight gain, some patients who don't develop weight gain. So those other comorbidities also, which may be evident as he mentioned, this is all part of the illness process, not as a side effect of the medication, And this is, I think, open to the all our attendees, that if they have any questions, we'll address them one by one.
We will take a
Bhaskar,
few
would you like to add
questions.
something?
Actually, a lot of things I could not say today because of time restrictions.
Right.
Okay. So whatever we have learned today, there are certain questions on that. So I think we'll take a few of them, and we may not be able to take all of them because of uh, time constraints. Uh, uh, Karthik, will you take the questions from
Yeah,
the?
I'm going from downwards. Can we treat narcissistic traits by modulating OCPD in attention deficit traits?
Narcissistic trait is something that is actually hard to define. And the problem in science is until and unless we define, we cannot solve it. Or if we discuss narcissistic trait or define narcissistic trait as a OCPD trait with very high self-confidence, then obviously there is background high level of motivational network process. So that involves various anti-impulsive medication there. So that is one way of treating it. Then there is low dose of antipsychotic and along with the usual anti-obsessive treatment. That should cover. But the problem is, first we have to define what we are calling by narcissistic trait. Because that is such a big name. There is no real scientific definition of narcissistic trait here. That is why I said so-called borderline, so-called narcissistic, because there is no scientific definition that we can use.
I think another question is about hazy auditory hallucination like phenomena. So, what would be the mechanism for such?
The auditory hallucination-like phenomena is actually auditory imagery, visual imagery. They are actually is a detailed pathway to that. It starts with imagery, then there would be a group of patients where the sensory discrimination process and the process of sensory evaluation in brain is not well developed. These people grow from imagery to hallucination. So imagery is the core. Now for imagery, low dose antipsychotic along with standard anti-obsessive treatment would help them most. Most of them would live normal life without any form of auditory imagery in case of this type of symptom. If we give low dose antipsychotic along with high dose of antidepressant along the line of OCD.
Right. Dr. Bhaskar, there's one important question about fatigue. Also, I would add to this, maybe there are some patients who complain of emotional blunting or they don't feel the
Yes.
euphoria or they
That
are not
one,
able.
that emotional blunting I would address first because that is a serious thing and we do not defend them properly. The thing is, imagine a lake, a small lake, two lakes actually, one small lake, one large lake. Now, let an elephant enter the two lakes. The small lake would overflow, would show huge disturbances of water, but the larger lake would not be such disturbed. There would not be overflow of any water and things like that. These two lakes are example of two brains with different functional capabilities. The small lake is the patient unmedicated who doesn't have very well brain function. So in them, any emotion has been overwhelming. They are not able to control their emotion. They talk rapidly. That's why these people are very clumsy in their day-to-day behavior, and ultimately they also have poor cognitive control, motor control, emotional control. Now, this is the group which can be called attention deficit with obsessive trait. Now, we give them antidepressant or so-called antidepressant. What will happen? Their brain function is starting to improve. And after a certain period, their brain would not go into overwhelming state when there is a motor challenge or when there is a cognitive challenge, or when there is a emotional challenge. So their response would be more subdued, would be more controlled. Now, since their childhood, since the day they are born, they know that that is how I want. I talk say, at the drop of the hat. I cry at the drop of the hat. I am clumsy. So when they start seeing that their emotional response, physical response, and cognitive response are getting more subdued, more sublime, they get scared. They start thinking that this is blunting. This is not blunting. This is actually brain getting more control over its output, and we need to make them understand that. Otherwise, they would, these are the people who would blame that medicine has made them blind. Medicine has not made them blind. If we want to prove them that your emotion is all right, we should add a low to medium dose of stimulant to their existing medicine regime. They would go into same form of emotional exuberance, they would go into same form of motor excess, and then we would say to them that, look, your brain's capacity has increased, that's why you are not feeling those kind of emotional high. I have given you some stimulants which would give you more emotional high, more cognitive high, and you start feeling again. That way, we can make our drugs blame free.
Right.
Do we want to take any more questions?
Malay, actually, I think people are saying that if next time we can have a kind of AI based,
Yeah, we'll try and do that.
There is
Summary.
option. Yeah,
There is
yes.
an option. There is an option. I think it will be transcribed. So let us see what is the quality of the transcription and all when the link comes up, when it's posted on YouTube.
Okay, I would keep a collar mic. Not a problem.
Right. So no more questions?
मेरा क्वेश्चन तो ले लो.
हाँ,
What is
डायरेक्टली
the
पूछ
que-
लीजिए.
Yeah, I think most of the no. Where is sir's question?
Just last question है.
Yeah, how psychotropics are different from each other in terms of their final common pathway.
Problem is, we know the gross pathway. They improve signal transduction. They cause various RNA-based and various transcriptome-based transcriptional change. They cause change in proteostasis. They can cause, and they do cause, change in various part of epigenome, that is the non-coding part of DNA. But unfortunately, that is the common general understanding. Fluoxetine might be affecting different part of epigenome than escitalopram. It is not might, it should be, because these two drugs are different. Similarly, fluvoxamine might be affecting different way to produce stasis than sertraline, but we don't have that much data. So these drugs are different. The common mechanism is same, but intricate individual mechanism would vary, and that would determine finally which should be preferred in which state. But we don't have that much reason. So at this moment, we would say they are different from each other in terms of their final common pathway, but how much different, where different, we don't.
Okay. I think we are well beyond our usual time frames. Your final comments, Dr. Karthik Rao.
I'm sure everyone has benefited from this informative talk, and we look forward to more of such talks from Dr. Bhaskar. And thanks for giving me this opportunity, and looking forward to similar talks from Dr. Bhaskar.
Thanks, Karthik. So before we end today's session, there are a lot of how would we put it? How can I put it? A different way of looking at things, uh, even in our bread and butter patients, as Karthik has put it across. What can be the take-home messages or the take-home message from a presentation like this, from a topic discussion like this? Number one is first and foremost, all the symptoms that we talk about in psychiatry and our diagnosis comes from the English dictionary. So it is very easy sometimes to confuse a normal experience for a symptom. We feel sad, but we are not depressed. We may feel depressed for a time, but that is not clinical depression. So for want of anything better or for want of anything different, we have these words which are in our vocabulary of symptoms, and they also go into making a diagnosis. So then it becomes very confusing because it doesn't point to any kind of a mechanism or an etiopathogenesis that can explain. And that has been our shortcoming for whichever diagnostic system we use. That's the first thing. Now, when we look below the symptom level, below these names, we need to understand what can be the probable mechanisms, because depending on the mechanisms, we can try and make our treatments work. Treatments do not work in thin air. Treatments do not work on opinions. Treatments are there because they work. Now, what can be the mechanisms broadly? Now, we have not evolved to that point where, if we use fMRI or if we use even whole genome-wide assessment, genome-wide studies, or even if we use exome studies, we'll be able to pinpoint that this is what is going wrong in this particular disorder. There is always an overlap. So barring that, if we look at symptoms, what do we need to look at? One and the most important thing is the history, as comprehensive and as detailed as we can get from the patient himself or herself, and from what we call as objective data, that is the relatives and people who have been in contact with the patient for a long time. Because again, if we are going to diagnose an illness, let's say today at 9:37 p.m., it is a cross-sectional diagnosis. It is what is happening now that we are going to start our treatment with. But what is now has been influenced over a long period of time and has led to what it is now. So we need to understand that long-term evolution of the illness, and that is where we need all the data. So a good history. One, we need to understand 3 generations at least, because that will give us a fair idea of how things have moved, not only in terms of psychiatric presentations, but also in terms of other non-communicable chronic disorders that would probably be going on in the family. Apart from this longitudinal history, developmental history, we also need to focus on the smaller things, because a child who is 2 years old is not going to have the same kind of presentations when he is going to be 20 or 25. So initial presentations can be more of temperamental presentations, more in terms of those soft neurological signs or minor physical anomalies. They become important in the long run. When we see them in a developing child, they are non-specific, but they add to the load of what is going to present as symptoms later on. So that becomes important. So one, we need to look below symptom levels. Second, we need to look at a trajectory level or a longitudinal level to be more certain what is happening. Now, in this, what is going to happen is, from what we understand, let's say two sides of the scale. One is the obsessive compulsive and the attention deficit. Now, what are these? Are they disorders? They are not disorders, but they function like traits. Only when we have a certain combination of symptoms, we would label it as an obsessive compulsive related disorder or an attention deficit hyperactivity. But what does it mean? It means an approach or avoidance. Given a stressful situation, what happens? How much do I approach that situation, cope with it, and how much do I avoid? There is a balance. Each one of us has this balance. And so a balance between this kind of traits, which is happening in the background. Different combinations, more obsessive, less inattention, more intention, less, gives us a variety of presentations. Now, how do we approach it treatment-wise? Treatment-wise, we will start with what is visible first. What is that group or the syndrome? And no drug is better than the other. Even if a guideline mentions use this as first line, it may just not work in my first patient. So guidelines are guidelines, but each molecule has its own way of working. And as Bhaskar mentioned in the last, that it's difficult to be very certain as to what individual drug does, but definitely two drugs are different from each other. They have their different mechanisms, even though if the starting mechanism can be an SSRI effect. An SSRI effect or a serotonin neurotransmission is just an entry point. What happens inside the cell, what happens to the second level messengers, all the enzyme systems, all the cellular processes, right up to DNA, right up to epigenetic marks, that is kind of variable. But it does happen, and it has to happen. Otherwise, there is no long-lasting change. Otherwise, there is going to be no disease-modifying change, and all this takes time. What also is important is the placebo effect. Placebo effect plays a role, and we should be able to identify it one way or the other. Placebo effects can be good, placebo effects can be nocebo also. So anything that is happening too fast, too unpredictable, this is one parameter that we need to look at. How do people respond? People respond differently. Given 4 to 6 months time, many patients will kind of stabilize. Many of them will have residual symptoms. And then depending on the residual symptoms, we may need to add or modify our treatment modalities. What are our primary modalities, the drug that we want to start with? Plus what else is happening in terms of anxiety? It is going to be the autonomic nervous system that is kind of playing up. Maybe we need to quieten it down. But over a period of time, we need to maintain that stability. We need to maintain the effect, whatever it is that has come with the primary molecule, and then kind of add something which, depending on what we are seeing anhedonia, we are seeing the downer kind of things. So whether we need a stimulant, we are seeing inattention, whether we need a stimulant or something else. Addiction that is happening, because many times when we start looking at addiction, we treat it, and then we find out a lot of things which are kind of at a level which are a little bit deeper. We'll see mood symptoms or mood instability, we'll see impulsivity, we'll see inattention. So what are we going to do for that? Only that one drug will be important, may not be important. We need to add something else. So this is how in clinical practice, with a good history taking, with an understanding of something that this is what is going to probably be happening, we will try and kind of tailor or customize our treatments for the patients. There is no one shot rule that this is number one, this is number two, this is number three. It all depends on how we are going to assess the patient, our history taking. In fact, when we treat patients, it's not only the placebo response, but it is also our own cognitive biases as clinicians as to what we prefer, what we are looking at, what we are kind of not going to give focus on. These are our biases, and we cannot wish them to be zero. So it's going to be a proper balance of the findings, what we are selecting, what is happening with the molecules in terms of side effects, and what remains. This is what I think we should take home with us. The basics have been discussed before, so I'm not getting into that. So we will look forward to the next session, and let us see what more we can learn from Dr. Bhaskar Mukherjee 2 weeks down the line, the fourth Wednesday of February. So thank you all for being here and spending your Wednesday evening with us. Thank you, Dr. Karthik Rao, for sharing it so well. Thank you, audience, for the questions. And last but not the least, thank you, BPS, for a wonderful collaboration where we are able to discuss a lot of things, both at a very basic science level and how it can be translated meaningfully into clinical practice, so from the bench to the bedside. And lastly, thank you to Alchem for being our knowledge partners and providing us the platform and the YouTube where we upload all these talks. Thank you once again, and let me remind you once again, please subscribe to our YouTube channel so that you do not miss out. Because if you do not subscribe and just look at YouTube, we get the lectures in a random fashion. You know, we do not get it serial wise. Subscribe and everything is there in a proper order so that you may pay attention. You can always write to us for your suggestions if you have any. And thank you so much, and good night and goodbye. Thank you.
Bye bye.
Thank you. Bye-bye.
Bye, Karthik. See you.
Bye.